for joining us. Yeah, I know we've got people in from the States, so it's their afternoon time. So I think you've been given a list, George, but others will come in onto my laptop, etc.
Okay.
On the screen.
I'm just gonna find my list actually.
Okay.
Because Alan did send it through, so let's find that.
Did.
Yeah.
He did.
Okay.
Right, before we start, can I make something clear to everybody? If I'm wriggling around, I've got a trapped nerve. Palak accused me of having hemorrhoids last week. I don't have hemorrhoids. I've got a bit of a trapped nerve, so I wriggle a lot. So please bear with me, everybody. No hemorrhoids. Okay, the background, this person says, I recently saw my consultant. The results from my blood test every 2 months show my ALT had gone up to 63 on the last one. So I think we mean by 63. It's been mildly elevated on and off for the past year. So he added in phenobarbital. I'm taking Urso. ALP is slightly elevated 113, and has been for a while. Prior to a blood test, I had my third Pfizer dose, had my chills for the second. After the third, flu-like symptoms back to normal. The consultant also spoke to me of me eventually coming off medications. I questioned this, and he replied both phenobarbital and Urso. So I think before we go any, right, okay. So I think we'll take the second question. My understanding of this, I should be on Urso for life. I wondered if this is a new thing in the world of PBC. You're not on Urso for life. Can we clear that up first, please, George?
Yeah, no, I think so. In general, people will be on Urso, as you say, for life. We used to stop it after liver transplantation, but actually that's also changing these days. Many people are resuming ursodeoxycholic acid immediately after liver transplant for PBC. So it is genuinely being used for life these days. So let's just unpick this though. I'm guessing that what's happened here is that the bloods were looking, they would, I don't know, the LT may have been normal before, then the fenofibrate was added. Perhaps the ALT went up after the fenofibrate had been added, perhaps. And that's maybe the reason that the consultant has become concerned. But then the person who's asked the question mentions that they had chills, mild chills, and flu-like symptoms. So I guess, I mean, this needs to be discussed with the consultant again, because unfortunately, there's not quite enough information here to make a really robust decision. So that, whoever has asked this question will have to go back to their consultant and just go through it in a little bit more detail with him or her. But it would be reasonable. It would be reasonable to actually wait and see what the bloods look like now that flu-like illness has settled down, because there's no doubt that when you've got a flu-like illness, your liver tests that is often reflected in the liver tests. We often see that the liver tests become slightly worse when a person has an illness for some other reason, and then they go back to their baseline levels when that other inflammatory condition has settled down.
This looks like the vaccine, George. I think what this person means is the vaccine.
After the vaccine, right? Well, that's yeah, and that would also fit in actually. That it's not unusual at all for people to have slightly abnormal Lfts after they've had the vaccine. So I agree with the person who's asked the question. Wait and see what the blood tests look like now that they have recovered from their slight pyrexia post-vaccine, and then make a decision about the medications. And I think probably worth clarifying also with the consultant once again. I suspect that the consultant meant that they should try stopping the fenofibrate and leave the Urso. I suspect that that's what they actually meant. But I think this whoever has asked the question probably needs to go back to the consultant and just clarify all of these things.
Yeah. It is important to say two things, that when they look at blood tests after vaccines or whatever reason, we get other things as well. Hepatologists do tend to look at trends. It's not one set of blood tests. Depends, very important. But also, going back to the Urso, I'm sure you've misheard that, but we have had this from time to time. But George is right; it's a rule. We're on it for life, by and large. It would be very, very unusual if you were to come off Urso. But if you can't get any more clarification, maybe you can give me a wee chat on the phone, and I can take some more details, and I can do something. I can ask more. And if it's too late tonight, then we can do it next week or the week after. We'll get some answers.
But Collette, exactly as you're doing, actually, what are the general learning points here? Well, you've already highlighted two of them. Firstly, as you say, once people are on Urso, they usually stay on Urso, even when the blood tests have returned to normal. Many people, in many people with PBC, the blood tests do return to normal after they've been on the Urso for a while. Well, that's good. That means it's worked, so you stay on it. So that's the general principle. Occasionally we'll stop it, but usually the reason for stopping Urso is going to be intolerance. So if the person is having lots of side effects on the Urso, that's a good reason to stop it. But blood tests getting better, that would not be a good reason to stop Urso. So that's general principle number one. General principle number two is exactly what you're saying, that we'll usually make decisions on the basis of trends. If the blood tests look wildly abnormal and really worrying, then of course you need to make a decision on the basis of that one set of blood results. But usually we'll wait and see what a couple of tests look like. And then I guess principle number three relates to what about fenofibrate. Fenofibrate is a very good medication. It improves the liver biochemistry in many people. One of the things it can do, though, is to push up the transaminases, and that's something that we will often monitor for. So if a person starts fenofibrate and then subsequent liver tests show that the ALT has increased and is trending upwards, then it would be very reasonable to stop taking the fenofibrate. But of course, this is going to be a decision that needs to be made based on all of the information available to the consultant and to the patient.
Okay. No, I think that's very good points there, George. Oh, sorry, my dog's just joined me. Hello, Holly. Beauty mascot. Okay, so the next one's making me laugh. What is Urso made of? It's synthetic. I know a bit about it. I can tell you what it's not made of. It doesn't come from bear bile, from polar bears who have horrific treatment over in different parts of the world. It is synthetic. It is made in a laboratory, and it mimics bear bile. George, I'm an accountant, not a scientist. Would you like to add on to that? I don't anymore.
Well, the simple answer is that yes, it is synthetic. Ursodeoxycholic acid is a bile acid, and it is now made through a synthetic process. The biochemists got together and worked out how to create it, and now they can do that. So they can synthesize it from chemicals in the laboratory. We don't need to involve bears in the story at all. But yes, what it is it's a chemical. It's a bile acid.
Which we have already, but we're just having more of the same. And if there's any issue with you taking your Urso, if you haven't gotten any side effects, there are other brands you can try, and it's often not the Urso itself, it's the capsule that's round the powder. They're made of different things, so don't give up. And there's always the nasty tasting liquid as well, suspension we call it. Very nasty stuff.
Those are good points to talk about, actually. So yes, so Collette, I completely agree. Actually, if people are getting side effects, it's worth ringing the changes and trying different brands of Urso. The other thing, though, is that sometimes Urso causes side effects if it's introduced at its maximum dose. So if, for example, you need a final dose of 1,000 milligram per day, starting at that dose can sometimes cause change in bowel habit, cramping, gripey abdominal pains, and so on. So I must admit, what I often do is to ease it in, start at a low dose and build it up, and then it's slightly more easy. That doesn't seem to cause any side effects. But yeah, ring the changes.
And can I also say that particularly during COVID time, and not just pointing figures, but our weight changes, and particularly a lot of people's weight has changed over COVID. And you need to keep an eye on your weight, particularly if you're not going to the hospital. Don't rely on your doctor. Keep an eye on your weight and check it. We've sent you all this chart. You can't see that very well with the lights. It's an imperial, it's in metric, and that tells you what dosage you should be on. If you know you have been on this for a while, and you can always drop your consultant an email and say, would you be happy with that? I put on a stone, I should be taking X amount. So I do like this, George. Isn't this fab?
Well, the next question relates to it, actually. Someone's used your Urso calculator, so that's good. Testament to its utility.
Yeah, it's a funny thing, actually, because I'll personalize this for a bit. I went to my consultant and he didn't recognize me because I've lost nearly 4 stone. I said, can I take less Urso? He said, I wouldn't bother. You'd probably put the weight back. Anyway, background, I've gained weight since being diagnosed, and I've been asked twice whether I should increase Urso on both calls with consultant. I'm told my bloods are fine, so don't need to increase. The Urso calculator clearly states I should be on 1,000, not 750. Can you advise what I should do? Great question.
Yeah, I think it's a difficult one, actually.
Yeah.
It's a difficult one. It depends what is meant by the bloods are fine, actually.
Yeah.
If the bloods are completely normal, if the alkaline phosphatase is now well within the normal range, then I can certainly understand why the consultant is suggesting that there is no need to increase the dose. Because, of course, what we're aiming for is to improve the liver biochemistry, and you can't get much better than normal. And a general principle in treating just about any medical condition is that you use the minimum required dose in order to achieve the outcome. So I can see where the consultant is coming from, if that is the case. That said, the recommendations are that patients who need to be treated with Urso should be taking between 13 and 15 milligram per kilogram per day. And if that puts this patient's dose at a dose of 1,000, then based on the recommendations, based on the guidelines, that would be the correct dose. I don't know that this is all that easy a question to answer, though, in reality, because where that dosing came from was from a pretty small study, and also only one study, where they essentially compared 3 doses and found that you got the greatest benefit at the dose of 13 to 15 milligram per kilogram. But the greatest benefit was an improvement in the biochemistry, and you could actually argue, well, if an individual can achieve the same benefit from a smaller dose, isn't that acceptable? The study didn't address those sorts of questions, and it was only looking at the biochemical response. It wasn't looking at the long-term outcome. So I'm afraid there's no easy answer to this question. All I can give you is I'm going to have to go with I suppose what's the correct term? I'll have to go with the guidelines. I'm going to have to go with the recommendations. The recommendations say everyone's got to be 13 to 15 milligram per kilogram. So I think I'm duty bound to stick with the recommendations and suggest that this person should be on 13 to 15 milligram per kilogram, and it's worth having another chat with the consultant.
Yeah, can I make a point here, George, as well? I don't like the word fine. And if my consultant, I'm sure they have said to me in the past, says, or doctor says anything's fine, I would ask them to define fine.
Yeah, well, exactly. Yeah. I think if it's anything other than normal, then up the dose. If they are normal, if the alkaline phosphatase is now well within the normal range, maybe you wouldn't get any greater benefit.
But let's just check with that. And in the PBC app, there's space there. If you put your numbers in, you might only do it once a year, twice a year. But if you want to keep a record of your numbers, I got really bored doing it after about 10 or 15 years, and I don't do it anymore. But some people like to do that, and they like to keep that record. So ask for your numbers, and you're entitled to that information. So it's not a problem. They will write you and send you anything you want to know. Just ask them numbers.
Yeah.
Okay, is that all right, George? Are you okay with that?
Well, it's fine for me, but I'm just worried now that people are going to listen to that and think, well, that doesn't make any sense at all. So shall we just really reiterate that, in general, the correct dose to be on is 13 to 15 milligram per kilogram. Yeah. And there's absolutely no problem with having another chat with the consultant and just just emphasizing that is the recommended dose.
Yeah. Good. Okay, I'm a 52-year-old female who had an AMA test 10 years ago, which was negative. My sister, who's 18 months older than me, was positive. She's now told by a consultant she's at the end stage of the disease and liver transplant is her only hope. Do you think I should take the AMA test again?
I'm not sure I'd do the AMA, but it would be completely fine to repeat the liver tests.
Okay.
If the liver biochemistry is normal, then there's no real advantage in checking the antimitochondrial antibody.
Okay. A good question, though. I hope your sister does well. We know, and George will know many people who've had liver transplants and they do fantastically well, don't they, George? It's a miracle. It's an absolute miracle. Are you all right? There's interference. Are you okay?
No, I'm fine. I'm fine.
Right.
I'm just wondering if there's anything more that we should speak about here. I suppose there are some general principles which are relevant here, actually.
Yeah.
And that's with respect to screening.
Yeah.
There's no doubt that PBC does run in some families. There's no doubt about that. And if more than a couple of people in a family are affected, then I think it's very reasonable for people in that family to get their liver biochemistry checked, their Lfts checked. At some point, for the sake of argument, shall we say 40? 40 would be a very reasonable starting point. Some people may want to get their liver tests done a little bit earlier than that. But where there's clearly a family history of the condition, I think it's quite reasonable for the members of the family to get tested. Is it worth getting screened in general? That's less clear cut, actually. Yeah.
Okay.
I mean,
sorry?
What we don't know from this particular question is why this person had an AMA test done 10 years ago, actually.
Yeah. Happy to look at this again if you want to send some more info across. About a question on my screen here is a very good question, actually. I've been prescribed penicillin. Is this okay to take? I'm responding well to Urso.
Penicillin?
You haven't got it. It's just come into me on my email.
Oh, okay, fine.
Linda's working in the background, feeding me more questions.
Yeah. Well, in general, I mean, penicillin is a very good antibiotic. It's been around for 70 years, 80 years. Many people have taken it, generally pretty well tolerated. So I can't think of any reason a person shouldn't take penicillin unless they're allergic to it.
Yeah. I think it's all, I would like to say at this point as well, if anybody has any doubts, we all take, different numbers of medication for different things. Don't hesitate to have a chat with pharmacists as well. I think they're a very underused commodity in this country. In many countries, they're extremely bright people. And they've got, their degrees, a real top-class degree. And don't ever hesitate. And if they can't tell you, which I'd be very surprised, about various medications and things, they know a huge amount. So don't hesitate. And I would also go on, I know it's not the subject, but I'd also go on to say about physiotherapists. They are fabulous. As in fact, it was mentioned last week, my physio said to me, doctors save lives and physios make it worthwhile. Yes, her husband's a doctor, but they are, I think people underestimate the tools that these two disciplines have in their bags, their tool bags. So don't ever hesitate to ask at the chemist or the pharmacist. Is that fair, George?
Yeah, no, absolutely. In fact, increasingly, I suggest that patients speak with the pharmacist because pharmacists can be very helpful for side effects. For example, previously, Collette, we were talking about how different brands of PBC can have different side effects. Pharmacists are going to know far more about that because they dispense the various brands. They'll know far more about that than the consultant will, actually. So that's, you can always turn to the pharmacist for that. But they also know about drug interactions. They know much more about drug interactions than doctors do. So this particular question about, am I safe to take penicillin? Well, in this particular instance, I'm completely comfortable with saying that, the majority of people are absolutely safe to take penicillin unless they're allergic to it. But in general, a pharmacist would actually know more about that than I would. So I completely agree. They're
Yeah.
a wonderful source of information.
We did a conference once in Bristol many years ago, and there was a pharmacist in our midst, and he said to James Newberger, "May I make a point in public?" And it was him that explained about the capsules around Urso, and that, you know, having different and he very much says that the pharmacy are underused commodities. So it was interesting to hear from his point of view.
Yeah.
Thank you for that, George. Okay, so we go on. We've got a few coming in now. The latest information about COVID vaccine in England states over 75s and other vulnerable groups will receive a further booster in the spring. I was wondering if having PBC, this would be considered at a condition within the vulnerable group, and should we seek the booster? I believe that the over 50s will be invited in the autumn for another booster vaccine, and perhaps this is sufficient. It's a good question.
It is a good question, and the answer at this point in time is no. However, there are caveats. Okay, so so the people who are considered vulnerable currently are people with cirrhosis. So if your PBC has reached the stage of cirrhosis, then you may well fall into the vulnerable category, and that might make you eligible for getting a booster. And by the way, for getting the antiviral treatments if you were to develop COVID. The other group with PBC would be those with overlap, PBC autoimmune overlap, who are taking immunosuppression. Immunosuppressed people are considered vulnerable, and therefore, they may also therefore be eligible for the vaccine and eligible for the antiviral treatments if they were to develop COVID. And then the final group would be patients who have PBC but have had a transplant for it, and are therefore taking immunosuppression. So those three groups would already fall into the category of vulnerable and potentially eligible for vaccine boosters. But if you have pre-cirrhotic, non-cirrhotic PBC, and you don't take immunosuppression, then actually you're not really at a substantially increased risk of severe COVID in the absence of other conditions, and therefore you're not currently eligible for the booster. But probably we'll all be offered a booster in due course. So
this particular antiviral you just mentioned there, so some people are receiving letters from the NHS, and people who have very mild PBC are receiving them as well. I think they've just not sectioned PBC in any way, and they've just seen PBC and they've gone for it. So if you get one of those letters, they come in the blue envelopes, the same as the vaccine envelopes. So if you get any dubiety, give us a ring or speak to your doctor. But some people are receiving them and have been for the last few weeks. The next question actually falls into that. Have you answered it? Do PBC patients come under suppressed immune system? Well, you've basically answered that, haven't you?
Yeah. Yeah, absolutely. But I mean, we can, by all means, let's go through it again. So non-cirrhotic PBC, a person who does not have, with PBC, who's not got cirrhosis and isn't taking immunosuppression, no, they don't have a suppressed immune system. If you have cirrhosis, though, then your immune system actually does alter slightly, and you do become slightly more vulnerable to infections. So people with PBC and cirrhosis, yes, they've got some natural immunosuppression, which makes them vulnerable. And PBC patients with overlap or transplant recipients, well, they'll be taking medications that suppress the immune system, so that will make them vulnerable.
And we've got another question, similar again, background. Diagnosed PBC 2012 after a wrong diagnosis 2011. I know it does happen. After a few years, liver test showed subtle changes, and I started Urso. Since then, condition stable, no cirrhosis. If I develop COVID and I feel quite ill, is there a number I can phone in order? I can order the antivirals without speaking to my doctor, because I believe the liver can be affected when COVID develops.
Yeah. So at this point in time, no. If this person is in the UK, then he or she would not be eligible for those particular medications, because PBC is not one of the criteria, PBC on its own. And the person has already said that he or she does not have cirrhosis, and as far as we can tell, he or she is not taking an immunosuppressant. So based on the information that's provided there, that particular individual would not meet the current criteria for receiving the antiviral agents which are being used to treat COVID. But that's not a bad thing. Let's reframe that. That's a good thing. That's a good thing, because those criteria have been identified, because those are the characteristics of people who do badly with COVID, right? The reason PBC hasn't been listed as one of the criteria for those treatments is because actually, based on quite substantial amounts of data now, we can see that people with PBC who don't have cirrhosis, who are not taking immunosuppression, they do fine. They do fine. They don't have increased risk of severe COVID. And that's good news.
Yeah, it's excellent news. Yeah. I hope that's reassuring. I'm going to come to the screen now, George, if I may, from Margaret. My consultant mentioned during my appointment, he said that they wouldn't even treat anyone with an alkaline phosphatase under 217. Now, I am assuming it was referring to someone already with PBC, as we were discussing my treatment. After the call, I find that rather surprising. Is this a normal protocol? I'm assuming you're talking about in Great Britain.
I think. I mean, Margaret would have to go back to that consultant and ask what exactly they meant. But I suspect, actually, when you delve into it, that in fact what the consultant meant was that he or she wouldn't add second line treatment to somebody whose ALK phos was under 217, and that would be correct in the UK at this point in time, because there's a general acceptance that the criteria for second line treatment in the UK is an ALK phos of 1.67 times the upper limit of normal, and that usually calculates as 217. I hope that's what they meant. We would normally give ursodeoxycholic acid to just about everybody, actually.
She's come back. She said no, just treatment, not secondary treatment.
Yeah, well, that's quite unusual, actually. That would be quite unusual.
In general, Margaret,
we would normally give ursodeoxycholic acid to anybody whose liver tests were abnormal. Alkaline, anti-mitochondrial antibody positive plus abnormal liver test equals PBC equals ursodeoxycholic acid. We wouldn't usually have a threshold of ALK phos 217 to introduce Urso.
Right.
So that is a little bit unusual there, actually.
Yes.
And I think the general principle for anyone else who's listening, the general principle is that all people with PBC should be treated with ursodeoxycholic acid, okay, and that's irrespective of how deranged the alkaline phosphatase is. But second line treatment is reserved for people whose liver biochemistry remains quite significantly abnormal despite that first line treatment.
Yeah, that's good.
Does that make sense?
Very much so. Yeah, it does indeed. I find I heal very slowly from the most minor skin sores, scratches, acne, etc. Once finally healed, the skin is left hardened and thickened. Is this common with PBC, or could it be something else going on?
No, that isn't common. That's something known as lichenification. It's not really a feature of PBC. So that would probably be worth. It's difficult to tell from a written comment what exactly is meant. It would be worth showing that to a GP or any other doctor, and just seeing whether there's anything else going on which might need some further investigation.
Okay. This person, I'm on Mesotrexy for rheumatoid arthritis, which is a very painful condition. I was told to get the booster. I'm still not sure. Any advice?
Right. So a person who's on methotrexate will have immunosuppression, because methotrexate is an immunosuppressant agent. That means that individual is more vulnerable to severe COVID if he or she develops COVID. So therefore, my advice is do get the booster, because the best way to avoid severe COVID is to have the vaccine.
Yeah. Okay. Is it normal for Lfts to go up and down?
Not really, actually. In PBC, generally, once treatment is started and once treatment is established, the liver tests normally stay reasonably stable. Not necessarily normal, but quite stable. They can go up and down for if there is something else going on, though.
Yeah.
So, for example, if you've got the flu, or you've had the vaccine, or something like that, the liver test can become slightly worse, and then they settle back down to their baseline after that other thing has gone away. They don't usually go up and down. There's not usually a natural variation in them, if you see what I mean.
No, unless there's other outside forces.
Yeah.
Okay, Margaret says thank you. I might actually bring up via clarification. Did I hear correctly? Good idea. But make sure when you finish conversation you've got an answer, because it's really important. And it may not be your fault. Maybe the doctor, she's not very good at explaining things. But do get the clarification. Can PBC cause bile acid reflux?
No, it shouldn't do that.
Quite a lot of people with PBC take Gaviscon and take omeprazole. Professor Jones felt there was a connection with Urso.
Yes, but I don't know what is exactly meant here by bile acid reflux as opposed to gastroesophageal reflux.
Oh, I see what you mean. Right. Okay. Right. If that person would like to clarify, then we will come back and answer that. I'm waiting results for a now SEH CAT scan.
Okay.
Right. Is bile malabsorption normal, common in someone with PBC?
No, it would be. That would not be. We would not see that as being a condition associated with PBC. Worth looking for. If the background was, for example, diarrhea, definitely worth exploring. But I wouldn't blame that on PBC.
Okay. I've called my consultant secretary asking for my dose to be increased as my weight is increased. I'm assuming they mean in Urso. I have heard nothing back for 4 weeks. Can my GP help prescribe my dose? Now, I'm assuming it's UK.
The GP can. I can predict, if this is in the UK, I can predict that the GP probably won't. It's not a bad thing, but increasingly GPs are reluctant to make decisions that would ordinarily be within the remit of the specialist. They probably would have been more, slightly bolder a few years ago. That's not a bad thing. You see a specialist for a reason. So if the GP is reluctant to alter the dose, I think be fair to the GP and go back to the consultant.
Okay. I'm still under test to determine PBC or PSC. If PST, would I stay on Urso?
Not necessarily. It depends a little bit on which consultant is looking after that patient. The current guidelines from the British Society of Gastroenterology suggest that people with PSC shouldn't be started on ursodeoxycholic acid. If a person with PSC is already taking ursodeoxycholic acid, the guidelines say that you don't have to stop it, but the recommendation is not to start it in the first place. So if the consultant looking after this particular patient, adheres to those guidelines, then the suggestion might be to stop the ursodeoxycholic acid. But there are other guidelines which are not quite so clear-cut, which say that you can use the urso if you want to, and it might be that the consultant suggests carry on with it.
Okay. Right, now we've got a bit of a story here. So background, I think you have this one, number 8.
Yeah.
Diagnosed with PBC in 2008 by biopsy as negative. AME is now, although it's now positive. Biopsy resulted in a bleed. This sounds very rare. A spell in ICU, jaundice, collapsed lungs, internal bruising. Took the best of a year to get back to normal. That is very, very, very unusual. Poor thing. Been a nurse since 2008. Approved for OCA 2018. But the prescription didn't materialise. Instead, was prescribed bisofibrate, and that's been since July 18 to present. I'm keen to start OCA, but MDT, what's MDT? I don't know what
the multidisciplinary team.
Or a treat team are requesting a biopsy that I'd rather not have. For goodness me, you can understand why. My consultant is taking me through my results line by line. Antibodies, Lfts, scans all seem to point to PBC. However, I haven't responded to current treatment as hoped, and results fluctuate. And you see the numbers there, the ALP. So I won't read all those out. And you see the GGT and the bilirubin has gone up to 41. He has Gilbert's or Gilbert syndrome, but this has historically been within range. Treated with azathioprine for 18 months in 2015, which did not improve results. Last fibre scan 13, these fluctuate too. MRI and ultrasound show signs of cirrhosis. I feel good. I'm mostly symptom-free, but would like to be proactive and avoid delay further damage if at all possible. We'd be interested to be involved in a trial, especially if I can bypass the need for another biopsy. Now, before we go on, I think I would like to address that thing about the biopsy, because I haven't quite heard of quite a reaction as that, and it shouldn't be, it's a very serious reaction. So she goes on, I do feel I've hit a barrier in terms of my treatment. I always ask about trials at my appointments, but I'm told there's nothing suitable. If there are any I could be considered for OCA or new treatments, that would be amazing, as we'd like to try and get on top of this.
Right. I think in reality, well, the first point regarding the biopsies, if a person doesn't want to have a biopsy, then that's the answer. You can't be forced to have a biopsy.
But they're basically bargaining with us, saying you can't have your OCA unless you have biopsy.
It's not the clinician's right to, we can't sort of withhold a treatment because there isn't a biopsy. And there's usually a way to compromise. So, for example, one option here would be to say, okay, a biopsy would be informative, but we're not going to do a biopsy. So what we'll do is a trial of treatment and see whether there's an improvement. If there is an improvement, that gives us the same answer. That gives us the same information that we needed, and we don't need the biopsy. If there's no improvement, well, we might need to come back to the issue of biopsy. Unfortunately, there's never quite enough information in the question for us to really say this is what you should do. I suspect that the reason that the consultant wants a biopsy is because he or she is worried about two possibilities. One would be overlap, autoimmune overlap, which would be a completely different approach to treatment. Okay, and the only way, unfortunately, you can find out if someone's got autoimmune overlap is through biopsy. And then there would be other conditions that you might consider, fatty liver, for example, which can significantly affect it can affect the effectiveness of treatment, but also you're not going to be able to see it unless you do the biopsy. So these are probably the reasons that biopsy has been proposed. But there is, as I say, if the patient is absolutely adamant that they do not want to have a biopsy, there is usually some way to get round that issue, which might provide you with the same information, recognizing that it also might not, and you might need to come back to the issue of biopsy. Probably the best way that this particular patient can get round this, I suspect, is to actually see another consultant who can go through all of the tests and see whether they come up with a different conclusion. So I think probably this is the right sort of situation for a second opinion, actually.
So given that she lives quite near you, then you would quite happily see her?
I mean, if she lives near me, then yes, I mean, that would be perfectly reasonable.
Mm-hmm. And the other thing that occurred to me, George, I'm always saying that doctors are human beings, chat with your doctor, they do want you to chat with them, but I can't even understand she doesn't want to have this biopsy. This must be hard for the doctor as well. Mm-hmm. What doctor wants to see a patient go through this? It's just, they would be thinking very, very seriously, I would imagine. I would imagine they're gung-ho about these kinds of things.
Yeah, no, that's a very good point to make. I mean, we're not actually, it's very rare. We're not cavalier about biopsies, basically. No. I mean, we recognize, most doctors recognize that biopsies can cause problems. it's very rare for a biopsy to have these sorts of complications, as described here. In fact, the majority of biopsies happen without any consequence at all.
That's right.
And they do provide extremely valuable information.
Mm.
But most clinicians will recognize that they can have complications and therefore will only recommend a biopsy when there's probably no other way of getting the information needed. And as I say, there is only one way to find out if someone's got overlap syndrome, for example, and that is through biopsy. So I do imagine that these are the sorts of questions that are being asked. But it's difficult to say without actually knowing all of the information.
I know she is watching this. She's spoken about this, and I said to her, we'd happily look at it for her. And if she's watching, we've got a few minutes left if you want to add any information onto that. But a second opinion seems like and you'll have more, or whoever she sees will have more information that they can perhaps make better decisions or different decisions or something. I don't know. She's only 40. She's young. But just going back again to this kind of response to biopsy, is it reasonable to suggest, as it's happened once, it may not necessarily happen again?
Oh, it's most unlikely to. Most unlikely.
Oh, now that's a good point. Can we talk about that?
Yeah. That's I mean, the risk of complications. I mean, I completely understand after that set of complications, I wouldn't want to have another biopsy either. I can completely understand that. But actually, statistically, there's no greater risk from of those set of complications with a second biopsy than there would have been for the first. And that risk would be less than 1 in 1,000 risk of having a significant complication such as a bleed, less than 1 in 10,000 risk of having a really serious complication such as near death. So, we're talking about really, really, really low chances of significant complications.
I've just had a question in here, a very good question that adds on to this. What is overlap syndrome?
Well, yeah, I mean, overlap probably isn't a very good term for it, basically, but most people with PBC do not have inflammation that settles down with steroids and immunosuppression. But a proportion of people have inflammation in the liver which resembles autoimmune hepatitis. They have that in addition to the changes of PBC. And that additional inflammation, which resembles autoimmune hepatitis, does improve with steroids and immunosuppression. And that's why it's a very important diagnosis to make, because if you do make that diagnosis, you've suddenly got an additional set of medications which you can use to improve the health of the patient. The reason it's called overlap is because there seems to be an overlap of the features of PBC with the features of autoimmune hepatitis.
Yeah, I remember listening to a hepatologist maybe 10, 15 years ago, and his belief was there's no such thing, and that it was an actual feature of PBC for some people.
Yeah.
So is that still the case, or are you quite clear-cut about it?
In my mind, it's all semantics. This argument crops up from time to time, and I think it's an incredibly boring argument, and I stop listening to it because it really doesn't matter. From a practical perspective, there are features of autoimmune hepatitis. It may not be autoimmune hepatitis, but there are features of autoimmune hepatitis which settle down on immunosuppression. And therefore, if you see those features, you add immunosuppression, the patient gets better. Done. To have an argument, a philosophical argument about whether it's this or that, and it's a donkey or a cow or a zebra. So what? I mean, it's the implications for treatment which are relevant.
Fair dues. Now, George, we've come to the end of our questions, which is fantastic. You're not going to be too late away, which is great. Is there anything you would like to cover while you're here? Any opportunity? For me, there's a couple of things I would like to say, and one of them is, you'll see from the last Bare Facts if you've got it on online. If not, it'll be coming to you in print. That I'm yet again talking about movement as medicine and up activity. You're not going to do yourself any harm. And because and this was in relation to this fantastic news that Professor Jones has his clinic opened up on the 14th of February, and it's about fatigue and PBC. So this is the clinic that's specialising in this. And some people were coming along saying, well, I have other conditions, I'm in a wheelchair, that's fine. There's still things that you can do. Movement is medicine. If you're bedridden, you can still practice movement is medicine. And I want to say to everybody, try not to think about what you think you can't do and have a bash at what you think might be possible. And again, if you've got other conditions, have a chat with a physiotherapist. You know, because they will keep you right. They'll put you in very, very safe, give you safe forms of movement if you are incapacitated in some way. And if not, and if you are able to walk, then please get out and walk, no matter the better. And it's good for you mentally, emotionally, physically, the whole works. I don't know if your patients engage in this, George. Do you encourage them?
I certainly encourage them to keep exercising. I think it's a challenging one, actually. I think some people are. My impression is that some people are slightly resistant to trying it.
Yeah.
But once they have tried it, once many patients have tried it, they do realize that actually they genuinely do feel better, not worse, after exercise. I suppose the only things are, what are the general principles? Give it a try, but start with something gentle, and build it up very slowly, as you can, and only then will you discover, I think, that actually it makes you feel better rather than worse, for a whole multitude of reasons. But it is a fairly natural consequence of fatigue that people will often think that actually they'll feel better if they do less.
Yeah.
And of course that.
Well, that's what they used to tell you in old days. Make sure you have a rest in the afternoon. And all it just made you was more and more tired. And you can actually buy into more energy. But I would also, I feel very strongly to say to people, you don't run out. you just don't run out of energy. You have some pockets there. And just give it a try. And if you're not succeeding with it, then come back and have a chat. But just give it a try. That's my message. We've got a question coming there, James. Have you had about patients PBC and cutaneous I can't say that word,
mastocytosis? I haven't, I'm afraid. So I'm not going to be able to help much there. I'm sorry about that. Yeah.
Any message you'd like to give to people out there for PBC?
No, I'm just wondering if we need to just explore this question 8. Just try and find the sort of general comments related to question 8 here.
Okay.
So I guess we've talked about biopsies and how in general we'll try and avoid them, but sometimes they are essential, and that the complications of biopsies are extremely rare. So anyone who's listening and has been told they're going to have a biopsy, do not be frightened. It is a routine investigation. Occasionally there are complications, but those complications are extremely rare. Okay, so that I guess we've emphasized that a lot now, which is great. The other thing that I was just wondering, though, is whether it's just worth mentioning that when people need second-line treatment for PBC, in general, the reason they need second-line treatment is because they do have more complicated, more aggressive PBC. And once they've started the second-line treatment, they will, exactly as in this case, there will be a period of monitoring the liver biochemistry to see what happens next. And unfortunately, there is a proportion of people, because they start out with aggressive PBC, there is a proportion of people in whom there won't be an improvement on that second-line agent. And then the multidisciplinary team will need to think about two things. Do you stop the agent that the person is currently on? And that could be bezafibrate in this case, or obeticholic acid, and switch to the other agent? Or do you add in obeticholic acid or bezafibrate, as the case may be, and see what happens? Okay. Or, as in this particular instance, do you completely stop and say, right, well, we need to approach this from scratch, and make sure that we're not missing anything. And I think, I suppose the point to emphasize is that none of those none of those approaches would be the wrong thing to do. It would be reasonable to switch agent and see what happened. It would be reasonable to add on the other agent and see what happens. And it would also be reasonable to say, well, okay, let's go back to the beginning and let's make sure that we haven't missed some other treatable condition. So I guess in this particular instance, you know, the team has decided that they want to approach it from scratch. I think that's entirely justifiable. But there will be other situations, and people listening will appreciate that, where the agent has been switched over, the other agent has been added, and we're now waiting to see whether there's an improvement. Unfortunately, medicine is never absolutely clear-cut. There's never an absolutely the right way to do things and an absolutely the wrong way to do things. Very often, it's all a little bit blurred and a little bit vague, and you have to see what happens to the individual patient, because each of us is different. I hope that, yeah.
I've got one last question, and it's a belter, because Gideon Hirschfield approached me while I was in York on holiday about this particular thing, and I was going to write to you and James and David Jones to say this is what's being raised. What can we do? Okay, so you'll get that email from me. So the question is: are urinary tract infections associated with PBC?
That's a slightly difficult one. There are epidemiological studies suggesting that they are. There have been studies. There was a study from Nottingham not so long ago, which had shown that people who'd had recurrent PBC, urinary tract infections, did receive a subsequent diagnosis of PBC, and that was a slightly better study than previous ones, which had just shown that people with PBC were prone to it. I think it's fair to say that there probably is an association based on those epidemiological studies, but that, of course, doesn't imply any kind of causality. So it's not that the urinary tract infections are necessarily causing the PBC. It's not that the antibiotics which are being used to treat the urinary tract infections are causing the PBC. It could work the other way around. It could be that something about PBC makes people that little bit more vulnerable to having them. So yeah, I would be willing to accept an association.
Okay, so Gideon came to me and said he hears that a lot in his clinic. For those who didn't know, Gideon Hirschfield is one of our medical advisors, and he's gone back to work in Canada. So Gideon had said he hears a lot about it in clinic, and also vaginal dryness. And so we appreciate PBC. It's 90% women. And let's be honest, quite a lot of us are that wee bit older and have gone through the menopause. So he's just a bit uncomfortable with the amount of times he's hearing it. And so I've suggested perhaps we look at a survey or a questionnaire or something like. So I'm going to speak to our doctors about that. So interesting, George. We might, and then if anybody out there, if you're interested in helping us, please do answer these surveys and questionnaires. Even if the answer is no, it's helpful to get what's happening to you. If we can capture that. So interesting, George, isn't it?
Yeah, but you make that other interesting point actually about dryness. I mean, PBC is there's a very, very strong relationship between PBC and Sjogren's.
Yeah.
And we normally think about Sjogren's as being dry eye, dry mouth. Actually, Sjogren's is dry everything.
Yeah.
It's all of the exocrine glands can be affected. So it's dryness of the eyes, it's dryness of the mouth, it's dryness of the skin. Dryness internally, you can have reduction in secretions, gastrointestinal secretions, but also as you're highlighting there, vaginal dryness. And if you've got vaginal dryness, then of course that's going to increase the risk of developing urinary tract infections. So there could be a very easy association there. Yeah. That's a very good point to make, actually.
Yeah. So leave it with us, everybody. I've got another 2 questions. You want to take these questions, George? You've got time? Okay, but leave it with us, and we'll come back to you. Okay. I saw in some forum that having nutrition genome test done can help the diet for the diet can help. I saw in some forum that having nutrition genome test done can help the diet good for the liver. Is this true?
Okay, there's no, unfortunately, there's not an easy answer to that one. There's no easy answer to any of these questions. There probably is a diet which is good for the liver. There probably is a diet which is good to reduce inflammation, right? Probably there's a perfect diet for PBC, a perfect diet for PSC, etc. But we don't know what that diet is. The studies have not been done, and it would be incredibly complicated to do the studies, actually, really, really complicated to do the study you'd need to do to prove that this particular diet benefits PBC, PSC, other inflammatory conditions. But I'm more than willing to accept that there probably is one, because nutrition is incredibly important, and we all know that.
It's absolutely important. And I would go on to say to people, keep the level of sugar down. Sugar is an active substance.
Absolutely.
And keep lots of this up. This is brilliant.
That's exactly what I was going to go on to, actually. If someone proposed a diet which was low in sugar, low in refined foods, low in additives and so on, and actually went back to basics, then I would be, completely in favor of it. The fewer the chemicals we put into the body, the better. And of course, it needs to be a diet which is going to benefit the rest of you. So a diet which is full of fruit and vegetables and has modest quantities of animal protein, modest quantities of animal fat, and next to no refined sugars, that's going to be a good diet for you. I get slightly more worried when I hear about things like a nutrition genome test. I don't know what it is, but it sounds faddish, and I would be just a little bit worried about the advice that came out from that, because it might turn out to be a very restrictive diet, which might do more harm than good.
What other problems? I'm a great believer these days, batch cooking. We're tired, we spend a lot of time batch cooking good food. I've been bleating on about Pinch of Nom, Nom, and they are big, colourful cookbooks. You can buy them for £10 a piece on Amazon. They're fantastic. You can batch cook, make up recipes in the freezer, and they've got all nutritious food. And I swear by them. I've bought them for loads of friends as gifts. One last question, and you'll answer it very quickly. Could it be possible having a positive AMA, high Lfts, and not having PBC?
Well, you could have syphilis.
Oh, George!
but that's pretty rare. That's pretty rare. The much more likely explanation: positive AMA plus abnormal Lfts, that equals PBC. Yeah.
I'm not going to ask you Edinburgh syphilis. I thought all those things were gone in the olden days,
Yeah.
That was our sex education in school. If you have sex, you get syphilis. And
well,
that was it.
Yeah.
Okay. I've had a great time tonight, George. Thank you so much. I'm seeing you Saturday morning for a trustees meeting coming up. Right, okay. So everybody, I hope we answered your questions well. And nobody in particular, I know who you are, and feel free to come back if you want to ask more, or you can see George. Thank you so much to people in the background. We've got Linda, Chris, and Alan working away, doing stuff in the background that's beyond my capabilities. And thank you for all our American friends for joining in as well. Here's Christopher. George, you're a wee star, so you are. Thank you so much.
Great. Thank you, George.
Thanks, everybody.
One last thing. Keep donating to the foundation. I've stopped asking, and James Newberg gave me a telling off. This service is for free. Come on, we need your funds. Are we going to our website and just put a few bob in?